Thank you, IFAS, for giving me this opportunity to present. So flat foot, I've gone when very brief for the PGs mostly. It's basically a condition where the medial longitudinal arch of the foot is lost. It is associated with conditions of hindfoot valgus, midfoot abduction, there's forefoot pronation and supination leading to Achilles tightening. This is basically the final common pathway. It is the endpoint. Once the foot gets painful, the medial arch collapses and the hind foot goes into valgus and forefoot goes into a break. So basically the foot is used for ambulation, as we all know, to propulse the body forward. And also now that we are in a shoe wearing community, we don't realize how important it is, how the foot works to manage the surface. If we go barefoot on different surfaces, we are able to run only because of the ability of the foot to regulate it. So coming briefly to the anatomy of the arch, the rigidity of the arch is formed by the bony component. The first tarsometatarsal joint is a rigid joint and it provides the rigid stability to the structures, but it is a very dynamic structure. The arch is not static, it's very dynamic. So coming to the supporters, the static structures are the spring ligament. Spring ligament is basically the hammock. Just below the talus head, it's the calcaneonavicular ligament which holds the talus head in place. Also, there is the superficial deltoid ligament, the plantar fascia, which helps to toe off. Then the long plantar ligament, which is equally important. Then coming to the dynamic supporters of the arch, tibialis posterior being the most common one, and the most common cause of adult acquired flat foot deformity is tibialis posterior tendon dysfunction. Also involved are the abductor hallucis and the small muscles, and the tendo Achilles playing a very important part. So as you can see in this video, the tendo, you can see the gastrosoleus, how it drives the arch forward once we try and do the heel raise. So what's the basic function of the arch? This is most important for the postgraduates to understand. The arch, it works as a shock absorber. It is a very rigid lever which makes us propel the body forward. For surface, it's very soft and malleable, so it can accommodate to the surfaces. It's a multi-purpose lever system with a reversed windlass mechanism, as you can see in this animation there. So what actually happens is, once the tibialis posterior goes into this function, the equinus happens, which is dynamic and progressive. The body tries to correct the equinus by going into valgus. That's where the hindfoot valgus happens. And the tendo Achilles goes lateral to the axis of the subtalar joint. This again, if the gastrocsoleus complex is tight, it is worsened, and the valgus keeps increasing to keep trying to propel the body forward, which leads to the medial soft tissue failure. And this soft tissue failure again leads to the progressive hindfoot valgus, and the forefoot goes into pronation. So again, this is very important for the postgraduates to understand the silver square test, how the knee, we check for the gastroc or the soleus contraction. So again, how we do the heel raise, you can see in the video, you try and do the double and the single heel raise test. If the foot looks okay, you repeat it 10 times. So you can see how the arch comes back when you try to release, and in this video the arch doesn't come back. Look at this, the tendo Achilles there, and the arch collapses on the medial side. So what does the tibialis posterior actually do? It acts as a shock absorber. It provides the support to the arch. It's a very powerful inverter and plantar flexor of the foot, which locks the transverse tarsal joint in mobility. It also brings the Achilles vector medial to the subtalar joint to maintain the posture while walking or running. So this is just a case to highlight the importance of the calcaneonavicular ligament. In this case, once you you can see the clinical picture here with the X-ray shade. You can see the talar looking downwards, the talar head looking downwards. And once you go get the MRI done, you can see the calcaneonavicular ligament is gone, and you can also see the tibialis posterior tendon hair on the MRI. Once you open it up, you see that the tibialis posterior tendon is in a bad shape, and the calcaneonavicular ligament is gone. So if you know what to look for, only then you can fix it. These are a few examples of the gait. There are rockers. Slowly with time, as the deformity progresses, the midfoot breaks. There's a video here. Look at this video. In this, if you look from behind, the hindfoot is okay. But if you see from the lateral side, you can see when the patient does the heel raise, the midfoot breaks. So it's very important to look at the patients from behind and from the side. So this basically is a dorsolateral peripteral instability. The hindfoot goes into valgus. There's the tight tendoachilles. You can see the valgus here. Then the arch collapses and the forefoot goes into abduction and supination. It's a very unstable foot mechanically, and the midfoot break is very progressive. So these are few cases where, in this case, the medial sliding calcanean osteotomy was done, and the talar head goes into the right position there. You can see in this video. So in brief, if there is a valgus hindfoot, I've not gone into the details of the treatment for the PGs. So if there's a valgus hindfoot, you correct it with a calcaneal osteotomy. If there's a tendon failure, you do a tendon transfer. If the spring ligament is torn, you either repair it or you augment it with the other tendons. Then if there is a talonavicular subluxation there, you repair the capsule and the tendon. And if there's a forefoot deformity, you do osteotomies, or if you are not able to salvage, like the bad medial forefoot I just showed, you go into fusion. So in summary, the medial arch is mainly the key to the bipedal gait. We are able to walk properly and run properly because of the arch. It is a very complex pathoanatomy. There has to be a very fine balance between the static and dynamic stabilizers. So when you are fixing these, you just don't have to fix the bones. You have to make sure all your ligaments are in place, all the tendons are in place, and you have checked for them when you're fixing them. Fixing the tendoachilles, tibialis posterior, the spring ligament complex, this is very crucial. And the earlier the posterior tendon dysfunction is picked up, is better. Thank you.